Hello and welcome to the lecture on dengue, a re-emerging disease. Let us delve deep into this topic, uncover the known facts about the virus and its impact on public health. From its origins to the preventative strategies, you will gain a comprehensive understanding of dengue and its consequences. Now, let us look into the historical perspective of dengue fever. Dengue fever was first referred as water poison associated with flying insects in a Chinese medical encyclopedia from the Jin dynasty 265 to 420 AD. The word dengue is derived from the Swahili phrase ka dinga pepo, meaning cramp-like seizure. The first clinically recognized dengue epidemics occurred almost simultaneously in Asia, Africa, and North America in the 1780s. The first epidemic of clinical dengue-like illness was recorded in India in Madras in 1780. The first clinical case report dates from the 1780 epidemic in Philadelphia and is by Benjamin Rush, who coined the term break bone fever because of the symptoms of myalgia and arthralgia. The term dengue fever came into general use only after 1828. Dengue virus was isolated in Japan in 1943 by inoculation of serum of patients in suckling mice. The first virologically proved epidemic of dengue fever in India occurred in Calcutta and eastern coast of India in between 1963 and 1964. Global distribution of dengue fever. The incidence of dengue has grown dramatically around the world in recent decades, with cases reported to World Health Organization increasing from 5,05,430 cases in 2000 to 5.2 million cases in 2019. Transmission of dengue virus occurs in Eastern Mediterranean, American, Southeast Asian, Western Pacific, and African regions, with new cases occurring and spreading to non-endemic regions in the United States and Europe. This shows the worldwide distribution of dengue cases between January and December 2023. South America reported the maximum number of cases, that is, 100 dengue cases for every 1 lakh people reported. India, Australia, and some other parts of Asia reported around 10 to 99 cases for every 1 lakh people. Some parts of North America reported 1 to 9 cases for every 1 lakh people. A vast majority of cases are asymptomatic or mild and self-managed. Hence, the actual numbers of dengue cases are underreported. Many cases are also misdiagnosed as other febrile illnesses. Overall, these dengue epidemics impose high costs to health services, to families, and to the economic systems of the affected countries. Dengue viruses are grouped into four genetically and antigenically related viruses that are known as serotypes 1 to 4. Infection by any of the four serotypes can result in a series of clinical manifestations for which the timing or sequence of infections can be an important determinant of disease severity and course. This shows the distribution of four serotypes from the year 2000 to 2014 across the world. Within each serotype of dengue virus, 4 to 6 geographically distinct genotypes have been reported. Dengue virus 1 serotype includes genotypes 1, 2, 3, which is also known as sylvatic, genotype 4, and genotype 5 and 6. Dengue virus 2 includes the genotypes Asian 1, Asian 2, Asian bar American, American, cosmopolitan, and sylvatic. Dengue virus 2 is frequently associated with severe dengue infections and epidemics. Dengue virus 3 includes the genotypes 1, 2, 3, 4, and 5. Dengue virus 4 includes the genotypes 1, 2A, 2B, 3. And sylvatic. Now, the transmission of the dengue virus. The female mosquito first becomes infected when she takes a blood meal during an acute febrile and viremic phase of illness. During the extrinsic incubation period, the virus first infects the midgut cells and then disseminates to replicate in numerous mosquito tissues, ultimately infecting the salivary glands 5 to 12 days later, a process that is influenced by ambient temperature, the viral strain, and the competence of the mosquito. Once the salivary glands are infected, the mosquito is infective and can transmit the virus to another patient during blood feeding. The mosquito remains infective for life and can infect every person it subsequently feeds on or probes while trying to feed. The time from infection to onset of illness in humans ranges from 3 to 14 days with an average of 4 to 7 days. Vertical transmission can occur when the infected female mosquito transmits the virus through the eggs to her offspring. But the epidemiological importance of this mode of transmission is uncertain. Now, let us look into the structure of the dengue virus. Dengue virus is a flavivirus that belongs to the family Flaviviridae. It is a positive stranded RNA containing virus. Dengue virions are spherical and are characterized by a smooth outer surface with a diameter of approximately 50 nanometer with the inner nucleocapsid core. The nucleocapsid is surrounded by a membrane called the viral envelope, a lipid bilayer that is taken from the host. Embedded in the viral envelope are the proteins, envelope proteins E and membrane protein M that span the lipid bilayer. These proteins form a protective outer layer that controls the entry of the virus into the human cells. The genome of each serotype comprises approximately 11 kb of positive sense RNA that encodes 10 proteins. The three structural proteins encoded by the genome are the capsid protein C, the membrane protein M, the envelope protein E, the non-structural proteins NS1, NS2A, NS2B, NS3, NS4A, NS4B, and NS5. Apart from this, it has a 5' untranslated region and a 3' untranslated region. NS1 is a 46 kilodalton protein that can be anchored to the endoplasmic reticulum or can be secreted. Intracellular NS1 is involved in early viral RNA replication. NS1 activates the innate immune system and is implicated in viral vascular leakage. NS2A is a 22 kilodalton protein that is a hydrophobic integral membrane protein. It is involved in RNA replication. NS2B is a 14 kilodalton small hydrophobic protein that serves as a cofactor for NS3. NS3 is a 69 kilodalton protein. It is a multifunctional protein with several catalytic domains. It is involved in nucleoside triphosphatase and helicase functions during RNA synthesis. NS4A is a 16 kilodalton hydrophobic integral membrane protein that is required for the formation of replication vesicles. NS4B is a 30 kilodalton small hydrophobic protein that suppresses interferon beta and interferon gamma signaling. NS5 is a 105 kilodalton protein that is the largest and most highly conserved dengue virus protein. It is involved in RNA synthesis and in the blockade of the interferon system. Now, let us look into the dengue virus replication and infectious cycle. Like a Trojan horse, The virus tricks the cell into letting it in. It enters the cell through receptor-mediated endocytosis. Once inside the cell, it uncoats itself to reveal its single-stranded RNA genome. This is a blueprint that needs to replicate itself. The cell unknowingly becomes a virus factory. The virus uses the cell's machinery to produce more proteins. This happens in the endoplasmic reticulum of the cell. These proteins are the building blocks for new viral particles. The cell now behaves like a construction site where the virus is the architect and the cell machinery is the worker. Next, it brings the RNA polymerase to the party. It produces a mirror image of itself. This is a crucial step as it allows the virus to multiply exponentially. With more proteins and RNA, the virus is ready for assembly. It is as though the virus is running its own assembly line and the virions are packaged and ready for exit. The exit is as tricky as the entry. The cell is still unaware of the intruder and helps it to escape through the process of exocytosis. Pathogenesis of dengue virus. After inoculating into skin, the virus infects macrophages, dendritic cells, Langerhans cells, which migrate to the lymph nodes and start viremia. Into the bloodstream, the dengue virus forms complexes with non-neutralizing immunoglobulins, infect macrophages and neutrophils. Infected cells start releasing virions. Non-structural proteins, especially NS1 and pro-inflammatory cytokines. Dengue virus directly infects endothelial cells, causing their rupture. Pro-inflammatory cytokines such as the tumor necrosis factor alpha and interleukins act in the endothelial cells, increasing their permeability. Non-structural protein 1 binds to endothelial cells and triggers the dysfunction of the endothelial glycocalyx layer by degradation of the sialic acid and shedding of heparan sulfate proteoglycans from the endothelial glycocalyx layer, which culminates in the loss of its integrity. Dengue virus infects mast cells, which release tryptases, disrupting the tight junctions, and bradykinins, causing the rash. Dengue virus induces the secretion of interleukin 1 beta by platelets, leading to the release of nitric oxide, a potent vasodilator. Dengue virus also infects stem cells, hematopoietic stromal cells, and megakaryocytes in the bone marrow, reducing the production of platelets, activating them, and leading to their apoptosis. Immunomediated complexes between antibodies and the virus or non-structural protein 1 cross-react with surface platelet antigens, inducing their destruction. Dengue virus activates the complement system by the mannose-binding lectin complex, triggering the cleavage of C4 complement and initiating the lectin pathway. Additionally, the classic lectin complement cascade can be activated by immunocomplex formed by antibodies linked to antigen proteins. Non-structural protein 1 can interact with the complement proteins, promoting the degradation of C4 and halting both classical and lectin pathways. These mechanisms lead to complement consumption and platelet opsonization and destruction. Symptoms of the dengue fever. Dengue fever symptoms typically appear 4 to 10 days after being bitten by an infected mosquito. Common symptoms include high fever, sudden onset of a high fever often reaching 104 Fahrenheit, severe headache. Intense headaches often described as a bone-breaking sensation, joint and muscle pain. Severe joint and muscle pain which gives dengue its nickname, breakbone fever. A rash that may appear few days after the fever begins. Mild bleeding, easy bruising and mild bleeding such as nosebleeds and gum bleeding. In 2009, World Health Organization introduced a new classification for dengue cases. This classification has proven to be a valuable tool for predicting patients with increased risk of disease progression. This classification facilitates early patient referral to intensive care unit, enabling better management of potential deterioration. Dengue fever usually occurs in people who live in or travel to endemic areas with fever and have any of the following criteria, such as nausea or vomiting, rash, aches and pains, and test positive for the tourniquet test. The tourniquet test determines the capillary fragility. It is a clinical diagnostic method to determine patient's hemorrhagic tendency. The test is considered positive if there are more than 10 to 20 petechae per square inch. Petechae refer to small purple spots caused by hemorrhage of the capillaries. Another criteria is the presence of leukopenia, that is, the low white blood cell count. Dengue with warning signs. These warning signs include abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, that is restlessness, enlargement of the liver by more than 2 centimeter, and laboratory tests such as the increase in hematocrit concurrent with the rapid decrease in platelet count. Severe dengue is characterized by severe plasma leakage leading to shock, or it is also referred to as the dengue shock syndrome, DSS. There is accumulation of fluid with respiratory distress, severe bleeding as evaluated by clinician, or severe organ involvement such as increase in aspartate aminotransferase and alanine aminotransferase, the liver-specific enzymes, or impaired consciousness due to the involvement of the central nervous system or the involvement of heart and other organs. Factors associated with severe disease. Host factors. Infants and older adults have a higher risk of developing severe dengue compared to middle-aged adults. Studies have shown that children are 5 times more likely to develop severe dengue due to their increased susceptibility to vascular permeability, while elderly have an increased risk of severe disease likely due to the presence of associated chronic conditions. In fact, studies have shown that individuals with diabetes mellitus have a 4 times higher risk of developing severe disease, while those with hypertension and cardiovascular diseases have a 2-fold higher risk. Similarly, individuals with renal disease and individuals with asthma have a 4-fold and 2-fold higher risk of developing severe dengue, respectively. Moreover, recent studies have also linked obesity with the increased risk of severe dengue due to its pro-inflammatory status. Sex has also been identified as a risk factor for severe disease. Multiple studies indicate that females, including young females, have a higher risk of developing severe dengue and higher mortality rates, although the specific mechanisms responsible for this sex disparity remain unclear. Another factor responsible for severe dengue is the immune status. Following an initial infection for a specific serotype, long-term homotypic antibodies are specific antibodies produced in response to the immunizing strain, and short-term heterotypic antibodies. Heterotypic antibodies are non-specific antibodies produced in response to other serotypes or other viruses are produced. The homotypic antibodies provide long-lasting immunity against a specific serotype and a brief immunity against all others. However, Several non-neutralizing heterotypic antibodies remain. During a second infection by a different serotype, the antibody-dependent enhancement phenomenon occurs, exacerbating the severity of the disease. Antibody-dependent enhancement is a phenomenon in which binding of a virus to suboptimal levels of antibodies enhances its entry into host cells, followed by its replication. Antibody-dependent enhancement may follow when a person who has been previously infected with one serotype becomes infected months or years later with a different serotype, producing higher viremia than the first-time infections. The interval between the first and second infection is an important factor. A longer interval may increase the risk of severe disease, probably due to decrease in circulating neutralizing antibodies. The same phenomenon may occur in infants born to mothers who are previously immune to the dengue virus and receive protective antibodies from them. This immunity could remain for several months. However, neutralizing maternal antibodies decline after this period, leading to a period of heightened risk for severe disease mediated by antibody-dependent enhancement. Similarly, antibody-dependent enhancement has been proposed as a mechanism behind the increase in hospitalization rates observed among individuals who were immunized before their first dengue infection with the CYD-TDV vaccine. As a result, the World Health Organization has recommended using this vaccine only for individuals with confirmed previous infection, that is, seropositive individuals. Additionally, previous exposure to Zika virus, a closely related flavivirus, has been associated with severe cases of dengue even during the patient's first episode. Due to the structural similarity between Zika and dengue virus, cross-reactive anti-Zika antibodies can trigger mechanisms of severe disease in patients infected with dengue, such as plasma leakage and shock. Virus strain is also associated with severe dengue. Although the clinical presentation of 4 serotypes of dengue virus may appear similar, they are biologically and phylogenetically distinct. The polyproteins of each serotype have been found to differ by up to 30%, suggesting that they could be considered distinct viruses. Further, each serotype exhibits different genotypes with unique geographic distribution and fluctuations in their prevalence occurring over periods of 2 to 4 years, likely due to the accumulation of immunity. These differences between serotypes and genotypes have a direct impact on the transmission and manifestation of dengue. While all serotypes are capable of causing severe disease, some are more likely to do so than others. For instance, studies have shown that the Asian strain of dengue virus 2 has higher propensity to cause severe disease than the American strain because it replicates more efficiently in human cells and can infect new mosquitoes more effectively, resulting in increased transmission. Genetic status. The severity of dengue fever is also influenced by genetic status of the host. Past studies have shown that individuals with the African ancestry are less susceptible to severe dengue fever, while recent research has identified several genetic factors related to the severity of the disease. The most extensively studied genetic factor is the human leukocyte antigen HLA, with HLA class 1 alleles being associated with more severe cases and HLA class 2 providing a protective effect. Other specific genes, such as polymorphisms in the Fc gamma receptor 2, tumor necrosis factor alpha, dendritic cell specific intercellular adhesion molecule 3, grabbing non-integrin, Janus kinase 1, cytotoxic T lymphocyte antigen 4, vitamin D receptor, human platelet antigens, transporters associated with antigen processing, and transforming growth factor beta have also been linked to severe forms of dengue fever. Diagnosis of dengue fever. Laboratory criteria for diagnosis of dengue include one or more of the following, which are used to detect the virus nucleic acid, antibodies, or antigens or a combination thereof. Demonstration of fourfold or greater change in reciprocal immunoglobulin G or immunoglobulin M IgM antibody titers to one or more dengue virus antigens in paired serum samples is indicative of dengue. Dengue virus antigen can also be demonstrated in tissue autopsies via immunohistochemistry or immunofluorescence, or in serum samples via enzyme immunoassay targeting the non-structural protein 1. Viral genomic sequences can also be detected in autopsy tissue, serum, or cerebrospinal fluid samples via reverse transcriptase polymerase chain reaction. It provides earlier and more specific diagnosis. Less frequently, dengue virus isolation from serum plasma leukocytes or autopsy samples, followed by cytopathic effect detection, has been used for diagnosis of dengue virus. Now, let us look into some preventive measures to control the spread of dengue viruses. Chemical control measures. Chemical control measures target the vector, that is, the Aedes mosquitoes. Chemical control measures involve use of larvicidals to stop the growth of vectors in big breeding containers. Use of insecticide sprays. Space sprays can be applied as thermal fogs and cold aerosols. Oil-based formulations are preferred as it inhibits evaporation. Some of the commonly used insecticides are organophosphorus compounds such as phenitrophenone, malathion, and pyrethroids such as bioresmethrin and cypermethrin. Chemical control measures are quite effective in controlling the vectors of dengue fever. However, they raise several environmental concerns due to their toxicity. Therefore, certain sustainable measures have to be taken to tackle this vector of the disease. Biological control methods offer sustainable solutions to tackle the vector. Some of the biological control measures include use of viviparous fish species like the Poicilia reticulata, commonly known as the mosquito fish. These fishes can eat mosquito larvae as soon as they hatch from eggs, and they can eat up to 100 larvae per day. These fishes can be used in water tanks or open freshwater wells. Only native larvicidal fishes should be used. Predatory copepods. This is a picture showing a female Mesocyclops copepod feeding on the larvae of Aedes aegypti. These freshwater crustaceans are effective in specific container habitats. Endosymbiotic control. Mosquitoes infected with Wolbachia, an intracellular parasite, are less susceptible to dengue virus infection than the wild-type Aedes aegypti. Apart from chemical and biological control methods, certain other measures can be taken to prevent the breeding of mosquitoes. Environmental measures include finding breeding areas of mosquitoes and eliminating the mosquitoes. Proper management of rooftops and sunshades to avoid stagnation of water. Appropriate covering of stored water like buckets and pots, etc., to prevent mosquitoes from laying eggs. Health education is the most important weapon to fight against dengue. Sensitizing the people regarding dengue in detail is necessary for the effective implementation of the dengue control program. The sensitization can be done by audio-visual media or mass awareness campaigns. Community participation is essential to sensitize the communities for their active participation in dengue control program. Now, let us look into some personal prophylactic measures to be taken to protect ourselves against dengue. Here are some key preventive measures. Use mosquito repellent. Apply mosquito repellent on exposed skin where Long sleeve shirts, long pants, and socks to minimize skin exposure. Stay indoors, especially during peak mosquito activity hours, which are usually early morning and late afternoon. Eliminate mosquito breeding sites. Ensure there is no standing water in containers, flower pots, or gutters where mosquitoes breed. Use mosquito nets. Sleep under bed nets if you live in or are traveling to a dengue prone area. Now, let us look into the vaccines under development for the dengue virus. Live attenuated vaccines. Antigenic compounds synthesized from a living pathogen that has been engineered to be less virulent or avirulent are known as live attenuated vaccines. Once administered, the viruses multiply locally, eliciting neutralizing antibodies and cell-mediated immune responses against the four dengue virus serotypes. These vaccines demonstrate the benefits of delivering protective antigens while offering long-term immune protection. Inactivated vaccines. Inactivated vaccines are antigenic compounds made up of denatured substances from other microbes such as bacteria and viruses that provide protection against the live pathogen. This vaccine stimulates immunity by using antigens from the capsid C, membrane M, envelope E, and non-structural 1 NS1 proteins. Although composite vaccines provide superior protection compared to single type immunizations. Recombinant vaccines. In this type of immunization, antigenic proteins produced by prokaryotic or eukaryotic cells generate long-lasting protective therapeutic immune responses. By far, the most prevalent dengue viral recombinant subunit candidates are the envelope E protein or shortened variants. These rely on the formation of neutralizing antibodies to prevent dengue virus from infecting its host cells. DNA vaccine. In the development of DNA vaccines, a gene encoding specific antigen is incorporated into the plasmid. The E glycoprotein anchored to the premature M protein mediates the first interaction between the dengue virus and host cells. Hence, it becomes a primary target for inducing neutralizing antibodies. Through in vivo injection of the expressed antigens, the vaccine induces both arms of the immune system, which are the T cell responses and antibody protection. Let us now look at the status of dengue vaccines under development. Live attenuated vaccines. Denguaxia, also known as CYD-TDV, developed by Sanofi Pasteur, is the only licensed vaccines available for use so far. It targets the live virus. The strategy employed in development of this vaccine is the replacement of the yellow fever 17D virus genes PRM and envelope genes E with dengue serotype 1 to 4 genes. However, its effectiveness is limited to certain age groups. There is also increased risk of severe dengue in seronegative subjects, but high effectiveness and safety is observed in seropositive individuals. Tetravax is another vaccine developed by NIH in collaboration with Butantan Institute Brazil and Panacea Biotech Limited India. It is currently in the phase 2 and phase 3 clinical trial stage. It also targets the live virus. The strategy employed in development of this vaccine is the attenuation of the serotypes 1, 3, 4 and 2/4 chimerical by excluding the 30 nucleotides from the 3' UTRN. The clinical outcomes are that this vaccine is well tolerated and it shows a balanced immune response in subjects. It is effective with the administration of a single dose. However, certain adverse reactions like mild rashes have been observed in certain subjects. Another attenuated vaccine is the TAC-003, also known as Dengvax, which is developed by Mahidol University in Virajan and Takeda. It is currently under phase 3 trials. It also targets the live virus. The strategy employed in development of this vaccine is the dengue virus 2 serotype PDK53 is attenuated vaccine coding sequences are replaced with dengue virus 1, 2, 3, and 4 coding sequences. The key clinical outcome is that it is immunogenic and well tolerated in multiple phase 1 and 2 clinical studies. It is independent of participants' age or serostatus. However, the safety profile is not entirely known. Another vaccine is the Tden F17/F19 vaccine, which is developed by WRAIR, that stands for Walter Reed Army Institute of Research Mission, and GSK. It is currently under phase 2 trial. It also targets the live virus. It is developed by involving primary cells of dog kidney and lung cells of fetal rhesus in serial passages. Clinical outcome is that it is proven to be a safe, well-tolerated and immunogenic dengue virus vaccine candidate in phase 2 trial. Now coming to inactivated vaccines. TDEV-PIV developed by GSK, Fiocruz and WRAIR Merck is currently under phase 1 trials. The target antigen is the inactive virus. It is synthesized by employing adjuvants and purified formalin inactivated virus. The clinical outcomes are that it is well tolerated, immunogenic in naive and seropositive individuals, and it presents no risk of reactivation and good immunological balance. Recombinant subunit vaccines V180, which is developed by GSK, Fiocruz, WRAIR, Merck. It is currently under phase 1 and phase 2 clinical trials. The target antigen is 80% of the envelope protein. The strategy employed is using the dengue 80E protein, which is a recombinant truncated protein. The key clinical outcome is that it induces steady immune responses against all dengue virus serotypes, decreasing the likelihood of the antibody-dependent enhancement effect. Nucleic acid virus vaccines. The TVDV vaccine developed by the US Naval Medical Research Center is currently under phase 1 studies, and it targets the premature protein M and E protein of the virus. These proteins are encoded via a recombinant plasmid vector. The clinical outcomes are that it is stable but lacks immunogenicity. Plasmid modification is required. Another nucleic acid vaccine under phase 1 study is the D1ME100, which is developed by the US Medical Research Center. It also targets the PRM and E proteins, which are encoded by a recombinant plasmid. The clinical outcomes are that no neutralizing antibody response was detected in individuals with low dose of immunization. Treatment of dengue fever. There is no specific antiviral medication for dengue, and treatment mainly focuses on relieving symptoms and maintaining fluid balance. Here's what to do if you suspect you have dengue fever. Rest. Get plenty of rest to help your body recover. Stay hydrated. Drink fluids like water, oral rehydration solutions, and electrolyte drinks to prevent dehydration. Pain relief. Over-the-counter pain relievers like acetaminophen can help alleviate fever and pain. Avoid non-steroidal anti-inflammatory drugs like ibuprofen, which can increase the risk of bleeding. Seek medical attention if symptoms worsen or if you experience severe abdominal pain, persistent vomiting, bleeding, or signs of shock. Seek immediate medical care. Now, let us go through a quick summary of dengue and severe dengue. It is estimated that 390 million people develop dengue virus infections every year. It kills one person every 12 minutes. It is a leading cause of death in children. Around the world, 4 billion people living in 128 countries are at the risk of dengue. It is a mosquito-borne disease which can be categorized as dengue with flu-like symptoms or severe dengue with life-threatening complications. It is the fastest spreading epidemic-prone infectious disease. It causes losses of several billion US dollars every year. How do people get infected? People living in urban environments are bitten by mosquitoes in and around houses. Virus gets transmitted through the bite of infected female Aedes mosquitoes, which bite during the day. The symptoms are high fever, severe headache, nausea and vomiting, muscle and joint pain, and severe dengue complications include bleeding and respiratory distress. There is no specific treatment available for dengue. Medication can be taken to control symptoms, but dengue can be prevented by not allowing mosquitoes to breed in stagnant waters in artificial containers. Remove or avoid all stagnant water which cover all water tanks. Mosquito bites also should be prevented. Wear light colored clothing, full body clothing, and make use of insect repellent aerosols, coils, or mats as per manufacturer's instructions. These are a few of the references and papers for further reading. Now, let us discuss some multiple choice questions on dengue. Which of the following is a primary vector responsible for transmitting dengue virus to humans? Aedes aegypti mosquito, Anopheles mosquito, Culex mosquito, or Ixodes tick? The answer is A. Aedes aegypti mosquito. Dengue fever is characterized by sudden onset of high fever, low blood pressure, hypoglycemia, or respiratory distress. Answer is A. High fever. Which of the following is the most severe form of dengue fever? Dengue fever with rash, dengue hemorrhagic fever, dengue shock syndrome, dengue fever with mild symptoms. Answer is dengue shock syndrome. What is the most effective method for preventing dengue virus transmission? Antipyretics, mosquito control measures, antibiotic therapy, or avoiding close contact with infected individuals? The answer is B. Mosquito control measures. There is currently no cure for dengue fever. What is the primary treatment focus? Antiviral medication, fluid replacement and supportive care, antibiotic therapy, or D. Vaccination? Answer is B. Fluid replacement and supportive care. What is the name of the first commercially available dengue vaccine? A. Dengvaxia, B. Tetravax, C. Mosquirix, D. None of the above. Answer is A. Dengvaxia. How many serotypes of dengue viruses exist? 2, 4, 5, or 8? Answer is B. 4. What type of virus is the dengue virus? A. DNA virus, B. retrovirus, C. flavivirus, or D. paramyxovirus? Answer is C. flavivirus. Thank you for listening. Beware of mosquito bites.